Welcome to the second session of Pulp Nonfiction. My esteemed colleague with me today, Dr. Carl Woodmansey from Montana and Texas. We first met down in the great state of Texas in Dallas in the grad endo program at Baylor, which is now quickly being phased out. The name Baylor, isn't it?
Yes, it is.
Texas A&M.
Texas A&M College of Dentistry.
There we go. Yes, and so prior to our meeting in Dallas, you were a general dentist for 17 years before you saw the light.
You bet. It took a long time.
Yeah,
I love general dentistry, and some days I still miss it.
yeah. You don't have to lie.
I don't miss dentures, and yeah, there's a few
Yeah,
things I don't miss.
yeah. No. I hear you. And in 2008, you graduated from endo, and you went back to your home state of Montana, and you started practice from scratch. You got it up and running, and then you went back into education.
I had a midlife crisis and decided to be an educator. Sold my practice in Montana, moved back to my alma mater in Dallas, and I have to tell you, being an educator is a hair on fire rodeo every day, trying to put out the fires of dental students and endo residents. It's really challenging trying to find solutions to those problems. I've been engaged with research. I've got more than 50 publications now. Just get a lot of engagement throughout the dental school, which is really stimulating. It's been great.
Yeah.
I picked up a master's in education in the last couple of years just to try to be better at that as well. So just learning new things is always stimulating.
Yeah, oh, that's fantastic. Wow, I didn't know you got the Master's of Education.
Yeah. Endo was a lot harder.
Well, because the Glickman didn't run the Master of Education program. It got nothing to do with you. Oops, we'll cut that one out.
He's going to come revoke your certificate, Joel.
All Americans are banned from Canada. I figure right now I'm safe.
That's right.
For about 5 minutes.
Oh, boy.
So back to the serious bits now. COVID-19, the coronavirus, has hit the dental world and society in general like a bat. And we're all reverberating from it, and things are changing hourly. I'm familiar with the situation up here in British Columbia and Canada, and I was interested to find your perspective down in the great state of Texas.
Yeah, I think there's so much to talk about here, and thanks for having me on your podcast. This is really great. I was a dental student back in the late '80s when the HIV and AIDS came into dentistry, and that really impacted our profession profoundly. And seeing that change back then, when before that time, dentists didn't wear gloves, they didn't wear masks, they didn't autoclave their hand pieces. So seeing how that impacted, really brought the whole point of having universal precautions and PPE into dentistry. Seeing that back then, it makes me think about where we are today and where we may be going. So I think those are the things that we'll talk about today. Here in Texas right now, we're it's a crazy time. It's a wild time here, I can tell you. Currently, Dallas County has a shelter-in-place order where everyone's supposed to stay at home unless they are an essential service. The dental school is actually an essential service because we're providing emergency care for both endodontics and extractions. And so I was at the school this morning in that capacity. And my colleagues throughout Texas here as endodontists their practices are just like yours, I'm sure, significantly impacted, having fewer patients, trying to find ways to be safe, but still take care of their patients and their patients' needs. General dentists are suffering as well. Many of them have closed their practices. The American Dental Association put out a statement essentially saying that all non-elective procedures should be discontinued. and many dentists are abiding by that. Here in Texas, our governor the other day put out a statewide order banning uh, all procedures that are not medically necessary or medically urgent, including dentistry. So, nobody should be getting their teeth whitened or anything like that now. And if you read some of the guidance that from a number of the organizations out there, they're making some pretty good statements. The ADA put out a pretty clear position paper because their first statements were really vague on what's a non-urgent procedure, non-emergency procedure. And so they have some pretty good guidance on that now. It's just basically, if the tooth doesn't have pain, you shouldn't be doing a restoration on it just for the hell of it. If you have a overhanging margin, you should only be addressing that tooth if there's pain. Nobody should be getting a prophy. Nobody should be getting an elective exam, things like that. So I think those guidelines are what we're living under here in Texas today. I will tell you that. And
urgent care only, right?
Urgent care only. And at the dental school, I will tell you, the dental students are now banned from the school. The dental students are totally banned from the school. Their clinic is closed. Their classes have been transferred to online classes. They're using Zoom meeting just like we are right now for their classes. Even our endo residents today had their topical and current lit seminars using Zoom meeting. So the digital age has really been forced upon education here. At the dental school, the endo residents and the oral surgery residents are the only people in the clinics, and we're there to see emergencies. I will tell you, in the past 10 days, we've not yet had a single endo emergency. Can you believe that? And I think some of that is patients are self-screening, smartly so. I think some of them may be afraid to come to a place like a dental school. I think people are protecting themselves and maybe trying to limit their own exposures.
Yeah. I know it's fascinating time. I had a general dentist call me, like this was last week, and she had a patient, and the patient had a crown, and the crown broke, and the crown had a sharp edge that was cutting her tongue to ribbons. And she's like, I got to see the patient. And I did a chatting to the dentist, said, okay, if this patient was on a desert island, would this ruin their day? Would they start swimming off island for help, or would they find a coconut and try to shave that thing down?
Yeah, take a nail file and emery board or put some orthodontic wax over it, candle wax over it or something. Yeah,
and that's what it had come to. I mean, this week it would be even stronger, but last week. And so I suggested, okay, and that's how I developed those patient instructions, because the dentist like, what do I do? So I said, okay, we want the patient to come in as clean as possible, and then you want the patient to go home, and you don't want the patient to contaminate the house. So these are the steps. But when the patient's then in the chair, in order for you to do that adjustment to that porcelain, you got to have a rubber dam on, and then you got to wash the teeth with the best stuff you got. So chlorhexidine, alcohol, bleach. I mean, just napalm the area, and then try your best to do the adjustment with the slow speed disc. And after that patient had that list of instructions, and then the desert island scenario, they're like, well, and we'd also say, maybe try to put some, temporary restorative material over it, to try to get to the edge.
Yeah.
You got to please yourself.
Right.
Well, we're not getting those calls this week.
Huh.
Yeah.
And I think ultimately everything comes down to clinicians' judgment, and that's where and we all have slightly different opinions. Come on, we know that. What one guy thinks is safe to do, another guy may think is dangerous. So and even we were talking at the dental school. I don't feel comfortable letting the residents work without an N95 filtration mask, because that's CDC guidance here in the U.S. and that's my position. When another faculty member is covering, they can make their own judgments there, and every practice is going to make those judgments independently as well.
Now that's a surgical N95 mask that's fitted, because there's
two
types.
N95, anything that's N95. Now,
okay, because there's industrial and then there's surgical.
And the CDC guidance isn't very clear on this, is it? If you look at the CDC guidance, it's not very clear. But But what I'm saying is we can't just use the old ear loop little tissue paper masks that we traditionally have used. You need something with higher filtration and N90 and with an N95 rating. And they have both the looks like a paper cone that's an N95, and they also have the hospital grade ones that are fitted masks that that they use for patients with tuberculosis and highly communicable, the Ebola things and stuff like that. But for this, I would feel comfortable. And again, everybody's going to have their own opinion on this, and because the CDC guidance isn't that specific, I would feel comfortable treating with just with any N95 filtration product.
And that's
they also have N95, P95, and R95 that are slightly different, but they all have the same 95% filtration.
Huh. Yeah. 3 weeks ago, N95, I would have thought that was like a Nissan.
Yeah, exactly. Yeah, exactly. Yeah, yeah.
A 4-liter?
Yeah.
Yeah, it's incredible. We're all learning so much more about masks. Now, for you with the masks, that N95, one patient, one treatment, adios.
Well,
some of the physicians.
If you have a truckload of them, sure, but I don't. Yeah. We're in an area. We have the problem here, and the reason that our governor has said no elective treatments really is he wants to preserve the PPE for the physicians. Yeah. So we can't be wasteful. We have to really be judicious and think about how we do these things. And there's not great strong guidance on that aspect of it.
Yeah, this is chat amongst colleagues, but some of the physicians were suggesting, that N95, you got to be judicious with, and you got to make it last. Maybe have a surgical mask over it.
Right.
And
try to find ways to extend the life of these masks so that
without being that obvious cheap guy that wore the same mask all week. It's like no. I'm actually, it's for the greater good.
And they do have ratings on. I think the N95 is supposed to have a 3-hour lifespan, I think is what technically it's rated at. If you get the P95, it's maybe 8 hours, and the R95 is 8 hours, and the P95 is 30 hours. So there's different grades of these masks that have different lifespans, and it has to do with, I think, how if they get saturated, then how well they protect against transmission or something.
We should tell you, residents.
You're way beyond my area of expertise here. I just know enough to say some numbers and letters there.
Yeah. Well, I'm convinced. So what you say to your residents is when they put on that P1 that's rated for 30 hours, you now have to do 30 hours of endo.
There you go. That's it. You betcha. Strap them in.
Boom. There you go. Yeah. So going forward, how are you looking at, and I know it's a dynamic and it's changed, but how would you look at protecting your patients and your staff and all that in the hospital setting or the university setting? And what would you basically conceive as, let's do that first, and then afterwards we'll think what would be good for, the outside world.
I really like the guidance that you published, and I hope you share it with your listeners here. Of how you're going to practice in your office, and I think there's some great wisdom there. One of the most common areas for disease transmission would be in a crowded waiting room. You just can't have 8 people sitting in your waiting room. Here in Texas, they ban groups of 10 or more. You can't have 10 people together, so you're going to really want to schedule people so they're like almost one at a time in your waiting room, or have a big enough waiting room that they can sit a long ways away. It probably depends how many operatories you have available for use in your practice. If you have open bay operatories, that's not great because you can have stuff floating all over. If you have closed door rooms or one closed door room that you can work in, that would be most ideal, certainly to contain anything. Having a limited number of staff. You're not going to probably want to have 80 people in your office, because in a busy endo practice, you're going to have a lot of staff. You're going to have someone doing your autoclave and stuff like that. Here, you're probably going to really pare down so you can have fewer people potentially exposed to anything. You're probably going to, the rubber dam is critical for isolation. High volume suction is critical. There's some authors that suggest, avoiding a high-speed handpiece. For endo, that seems impractical. I really can't imagine totally accessing a pulp chamber with just a spoon excavator, although the group...
And you're really going to need that 30-hour mask.
Yeah, exactly. Although that one paper I shared with you from China, they talked about excavating to expose the pulp and then placing devitalizing medications on the pulp. And yeah, it's like that's a little too crazy in my opinion. Now I will say this, I think our goal is to provide emergency procedures for our patients, which means, do we need to do single visit endo, or do we just need to do enough to relieve their pain and get them out the door? Is it just a pulpotomy? Is it just a pulpectomy? Or is it really time to obturate and place a permanent buildup in that tooth at that same visit? So I think those are things that each practitioner is going to need to think about in those decisions.
Yeah, I would tend to say that if you're comfortable and you're in the canals, shut the door. Because this could be going on 18 months.
We don't know. We have no idea.
Yeah, we have no idea. And so if you're comfortable, if it's an irritable pulpitis case and you're comfortable and you've reached the lengths and you're happy with it, I'd be tempted to finish the root canal, place the core.
Most of us would be as endodontists.
Yeah.
General dentists maybe not as efficient as we are.
Well, yeah. And you don't want to necessarily close the door to have to reopen it again soon.
And I think, one of my colleagues asked me yesterday, he said, I've got a tooth that needs an apico. The patient has pain 6 out of 10. Should I do the apical surgery? And it's like, wow, that's a great question.
Yeah.
I don't know. That's where clinical judgment, each practitioner has to make that decision.
Yeah. Yeah. And I would also, in some regards, take the monkey off our back a little bit and run that by the patient as well. Like, okay, wait a minute, this is what you're looking at. And all of a sudden, maybe that 6 is now a 4.
Yeah.
But if they're hard on that 6 and it's creeping towards a 7, then you're like, okay, well, or maybe they'll go to an extraction. And I know it hurts us to say it, but it's like, well, needs must, desperate times.
Yeah.
The less time in the chair, the less time in our office, the safer.
Yeah, exactly. And and there's some guidance that you may have read from the American Association of Endodontists. Ken Hargraves was on that paper where they talked about different ways to medicate teeth. But it's like, we can't have our patients living on medications for potentially 3 months, or being on antibiotics for potentially 3 months and things like that. So there needs to be some definitive treatment. And at some point, if it isn't endodontics, extraction may not be the worst thing in the world, because people's lives are more important than a tooth.
Yeah. And that really hurts to say.
Yeah. And your health and your staff.
Yes.
And your family and your father and your father-in-law and everyone that you're potentially exposing people downstream to is a consideration for us all as well.
Yeah, no, absolutely. Now with this, the development of teledentistry.
Yeah.
How's that been from your experience?
So, we haven't Zoomed with our patients yet, but I think that day is here now. Yeah. And I don't know if you've done that.
I was going to have you talk about mine too. I can't find a good endo up here. I need to go to Texas.
As practitioners, we end up breaking all the HIPAA I don't know, do you have HIPAA in Canada, Joel?
No, but we have similar
privacy rules, and
to the nth degree.
I mean, we'll be endodontists. We're using our iPhones and texting X-rays around all the time. What do you think about this case? And things like that. And so we've been using some sort of teledentistry in that way for consultations with our colleagues and all. But now there's a place for it directly with our patients. And I think that's really interesting. At the school, we're doing screening calls. And I think you talked about this in your practice philosophy handout that you shared, where basically you're doing a phone consultation with the patient in advance of the treatment. So, because you may be able to save them a visit to come in. In fact, at the dental school, we had one last week where the student said, oh, I'm in terrible pain. I need to be seen. I got referred to the endodontic department. And so we called the patient and we said, oh, so who referred you here for a root canal? And she goes, no, I don't need a root canal. I need my tooth extracted. That's why I'm coming. It's like, okay, so we were able to prevent that patient from getting into our clinic just by making that phone call. And it's just a great communication tool, whether it's telephone or Zoom or Skype or FaceTime or whatever today.
Yes, no, absolutely. They're actually the insurance companies. The physicians are already on track with it, chatting to their patients, and it's a billable procedure. And dental insurance companies are talking about it as well. It's a billable procedure because it is your time, and it's something that we need to do for the greater good of everybody.
Yeah.
Yeah.
Physicians have already been doing this a lot, especially in I've seen it when I lived in the St. Louis area. There was a whole ton of physicians that did this, and a lot of patients would just go. They wouldn't go to their primary care physician or to CVS or Walgreens to see a nurse practitioner. They would Zoom in to talk to somebody, and they'd get a prescription and go pick it up, which is, I think,
Yeah.
really great.
Yeah, no, like going back 3 weeks, I was chatting with another dentist and I said, it's absolutely crazy because sometimes we have patients who referred to us and the general dentist, is now considered we're the primary care person. We haven't seen the patient yet, but their pain's cascading out of control and they want a prescription. And it's like, well, I haven't got a medical history.
Yeah.
And I'm loath to phone in a prescription because I just know the governing bodies are going to come down on me like a ton of bricks.
Yeah.
Well, now with teledentistry, I think that's changed because what happened was this scenario happened just last week with me. I phoned the dental office. I got them to email me the medical history. The patient knows about this. I reviewed it. I phoned it in. And I think that's best case. That patient didn't have to come in to see me, and it's a greater good for everybody. And this whole email and HIPAA thing, I do remember HIPAA went down and says, I get asked to give opinions on legal cases. Lawyers email me everything.
Right. Yeah. Yeah.
So I just can't wait for that case to come up because then I'll be like, you guys serve me via email about the email case that I talked about. Like, whoop, it's a wish it. And if you mail stuff, general mail gets misplaced and lost.
Yeah. Now I know you've done some satelliting way up in Whitehorse or somewhere up in northern
part of Canada, the Yukon. Yeah.
Yeah, and even in my practice in Bozeman, where I had patients sometimes driving 200 or 300 miles to come see me from remote parts of Montana. And then they'd get home and they'd have a post-op complication or a flare-up or swelling or their suture is something or another. And so, they'd often I'd have them take a selfie, have somebody take a photo, or they'd send me or we'd FaceTime so I could look at their swelling or talk to them. And I think that may be an example of teledentistry too. And I think there's some really cool applications of things that we didn't even imagine 15 years ago, that technology.
Yeah. No, and it's really going to be a saving grace for us now. If we had this pandemic now in the 80s, it would have been harder to deal with the phones or have them as effective as they are for us now.
Yeah.
And one of the things I'm doing in our office is we took all the chairs out of the waiting room.
It's funny here because all of the restaurants here in Dallas are closed. You can only you can't go to a restaurant here in Dallas. You can only get takeout or drive-through stuff. So I went to get some takeout at a barbecue joint the other day, and I went in there.
Oh, I missed those.
The whole restaurant has no chairs, all these tables, but no chairs because they want to make it abundantly clear that you can't stay there to eat your food.
Yeah.
So your waiting room is a no waiting room then. That's great.
Yeah. It's kind of, it's like, you just come in. And so the game plan we're going, because it's still early days and we don't know the lay of the land, is the patients are actually supposed to be wait outside.
Right. So you don't have to disinfect that chair then or worry about that.
Yeah. And then when we've done with the treatment of the patient inside, that patient leaves our office, then the staff and I can clean everything up. And when we're happy, we bring in number 2, like the new one comes in.
Right.
And that's the, and then you're really conveying to the patient, this is a big deal. This is something. and you're doing as best you can in the circumstances. And yes, there's no study to prove that, but let's not wait till the bodies pile up till we have a study that proves that that's the right way to go. And if we're proved wrong, it's because we overcorrected.
Well, we have some data. There's some data on one of those Princess cruise ships that the virus lived in staterooms for up to 9 days.
Yeah.
So, I mean, we know that it can live on surfaces and be transmitted by touch. It's not just, certainly aerosol spray is the way that they think it's most commonly transmitted, but we don't know that for sure yet.
What do you think about surgical handpiece for endo access? It's blowing less air, less get air emphysema.
I'd say I'd cut dry. Why do you even need water?
Yeah, no, well, exactly, but turn off the water even on your surgical handpiece.
Sure. Yeah. So are you talking like a compressed gas handpiece or an exhaust where it exhausts out, not in the front? Yeah. I think that's probably a great idea. Yeah. Why blow stuff around?
Yeah. I know. And exactly. I mean, cut dry. Yeah. And you know what?
Unless you're going through a zirconia crown or something, it's going to be tough as hell to get through, but
you don't want to cook the PDL, but short of that, everything's being fried.
Yeah, the pulp's not going to survive. Don't worry. But one way or another.
Yeah, we're in a killing mode.
Yeah. No, I like that idea about a surgical handpiece. I really hadn't considered the exhaust on that, where the surgical handpieces are not exhausted into the space. Yeah.
Yeah, and no more cutting holes for breathing and rubber dams.
No, I really rarely do that in the first place.
I always found that stupid because you put the rubber dam halfway, they got a big hole here, and then you cut a hole there.
It's more of a placebo effect, I think, for these people. It's like, if you can't handle that, then you probably need to either be sedated or things like that. Another thing to think about, though, talking about sedation, and I don't know if you have this in your practice, is nitrous, because the nitrous tubes, can those be decontaminated effectively? Should we be doing nitrous on patients today? I don't know.
No, you're absolutely right. That's something that no one's brought up till now. But that maybe those nitrous tubes, that's
too many unknowns here, aren't there?
Yeah, it's probably best to stay away from nitrous completely.
Yeah, and if you those things may just need to be extractions instead of endo in those cases, perhaps. I don't know. Those are tough decisions. These are ethical decisions too, at some level. These are tough choices about what's appropriate and how safe is safe enough.
I have a very funny nitrous story for you.
Okay.
We hooked up the nitrous. We had this guy, nice Polish immigrant guy, and he's like, I'm really scared. It's going back a couple of years. And I was like, I don't think this guy's that dental phobic. He's telling me he's really scared, but he's like me right now saying, I am terrified. I just really, okay. So anyway, we set it up and we have the auction, we're going and we have no nitrous. So we go through the whole kid computer, the whole motion of it. And are you feeling lightheaded? Feeling tingling in your toes. You're doing really well. He's like, yeah. We go through the whole procedure. He's just breathing oxygen the whole time. And then at the end, I go, you did so well. We're not going to charge you for the nitrous. And he goes, oh, thank you very much. My assistant was looking at me like, oh, nitrous. I'm like, we got oxygen. We're okay. Just don't go no oxygen. But we're no nitrous. We're flying.
Placebo effect is strong, isn't it? That's another.
Yeah. He was awesome. Yeah. But
that's great.
No, that's a great point. I'm going to, I don't use the nitrous much, but I'm not going to touch that thing with a barge pole. And to be honest, I don't know your experience. My experience, you give him a lorazepam, you take him get him to take a Tylenol 3. Lorazepam will never ride to and from the appointment. And you get him to take a Tylenol 3, and you give him a bucket load of freezing, and away you go. One of the things I will change, though, is whenever I had a person with irreversible pitus, and I'm doing the access with the rubber dam, if I got any sense that they felt it, I would take off the rubber dam, do my PDL or my intraosseous, but then I would leave the rubber dam off
Right.
till I got access in the chamber, because I don't want to go through the song and dance now
Yeah.
of ho ho ho. Well, now that rubber dam's going back on.
Yeah. Yeah.
Yeah.
Yeah.
So yeah, that's going to be tough. Now, the two articles, I'll put them up, but mitigation and suppression. I thought those were fascinating, because mitigation and suppression. I mean, if in the study, it was like, if they do their best at mitigating the problem in the U.S. and the U.K., it was like 8 times the capacity for surgical beds.
Yeah.
And suppression is going to mean a massive impact on the economy and our civil liberties.
So what you're talking about here, Joel, is this article by hang on, I don't know the right one. So
Neil Ferguson.
It's the one. It's the
Impact on non-pharmacological interventions to reduce COVID mortality.
Yeah.
Yeah.
Yeah. And that's kind of one of the reasons that Dallas implemented this shelter-in-place order, because they project, like, if they did nothing, it would just spike huge the number of hospitalizations, and they show that the number of hospital beds is here at like 4,000 hospital beds, and the number of ventilators is like 2,000 or something like that. So just you'd have a ton of people dying. And then they talked about, well, they showed another curve that showed if you just did social distancing, and it reduced the impact by about half. Yeah. But it still far exceeded the number of hospital beds available. And so then they showed another projection, which was if they had people shelter in place, to even further reduce social contact, and that kept the number of sick people below the number of hospital beds. So theoretically, it will save lives.
The staying at home
saves lives.
Yeah, which was incredible, and we're happy to share this with the wider world. But it was quite interesting, because when you get all these recommendations, the suppression versus mitigation is lost. But when you read the article, it's like, whoa. And one of the interesting things was, big groups, gatherings aren't that bad. Not that we should have them, but my thought was they were going to be way more impactful than they are. I mean, I'm saying that we should have them, but I was surprised because they said the actual interaction that people have is a short term.
Right.
And so having a bunch of people in an office tower, way more impactful than a 2-hour concert. But not that we should do the 2-hour concert. And then the whole thing was, as soon as you ease it off, you could get a spike.
Yeah.
And if you're too good at suppressing it, there might not be enough innate
the herd immunity. Yeah.
Immunity, that you're actually overcorrected too much, and then we're all kind of weak flowers, not ready for the bad bug, because we were so good at suppressing. So you have to let some people get sick. I mean, it's like, whoa.
Yeah, here they're talking about flattening the curve, and that's trying to just get it below the number of, suppress it below the number of hospital beds available, and I think that, and we see like Italy didn't do that, right? They're behind the power curve there, so now they have people sleeping, on floors in hospitals and things like that, which is just horrible. And the numbers of deaths there is horrible, and they're having to make these life and death ethical decisions about who gets a ventilator, and if you're over a certain age, and if your BMI is whatever, and if you have certain medical conditions, sorry, Charlie, you don't get a ventilator, you're gonna die. Yeah. And that's what we're hoping to prevent, if we can flatten that curve, and if people can just stay away from each other long enough, I think.
And it's not just a lack of machinery in Italy, it's the lack of people to work the machines, because then the people are just spent and they're now sick. And so in some cases in Italy, I think they had the machines, but they had no one to operate them.
And yeah, and that brings up the point of China, which is our one glimmer of hope this week, because China finally really has flattened their curve. They have really no new no new cases of community transmission, which is pretty remarkable considering where they were 3 weeks ago.
Yeah.
But China is different than here in the free world, because they were able to get 7,000 workers to work 24/7 to build up that hospital in Hunan. They were able to import physicians from all over the country to come work in that crisis. You know, do you think, are we going to be able to get physicians to go to New York City today to work in the hot zone? People aren't going to probably, there'll be some altruistic people that will do that, but a lot of people will fear for their lives, unfortunately.
Yeah. Yeah.
And that's just the difference of a China versus the free world. So.
Yeah, well, and I saw it too, and I was interested because they showed, and again, it could be fake media or whatever, but they showed these trucks going through the city of China, in Chinese cities, pardon me, and they were spraying chemicals at night.
Yeah.
And they're saying they're disinfecting the city, and you're thinking, well, is it just soap and water because that works really well in coronavirus, or what is it? Well, you know what? Maybe that needs to be done here, and you could just imagine 3 weeks ago, or yeah. I mean, but I think that the tolerance for it is fast approaching, because you're like, holy, this is bad.
And you know, also in China, they did things like people with fevers were they were there locked in their house, physically locked in their houses.
Yeah,
that would never fly in BC, or they were forcibly taken away, and things like that, which is crazy. And here in Texas, since you spent some time here, Joel, you can relate to this. You know, Texans think that they are, you know, it's a different world here, and they think that they have this independent spirit, and no one's going to tell us what to do because we're Texans. And that's where it took a lot for the governor here to have this order mandating mandating that only urgent medical procedures, dental procedures could be done. And that's why we only have local ordinance and county ordinances with shelter in place, whereas New York, California, and Illinois, and 2 other states have statewide shelter in place orders. Texas is never going to do a statewide shelter in place order because they think that civil independent liberty is more important than public health. It's like, wait till enough people die, then it's like, and then if you're in Italy, you're behind the power curve. It's too late to shelter in place won't work then.
Are there enough people like with their own homesteads out in the country? Is that where that sentiment, or is it like, I can imagine in the city that homestead mentality might crack away a little bit, because you're like, I'm right next door to my neighbor, right, and we go to the same store. Whereas if you have your own farm and you're out in the middle of nowhere, you could still buy into that. But I think if you're in the city of Dallas, you'd be like, yeah, I get it, that's a Texas mentality, but I want to see next week.
You're exactly right. Some of the rationale here is that there's still quite a majority of counties in Texas don't yet have a documented case. Mm-hmm. So those counties are like, why would you impose shelter in place on us? We're not even infected yet. And I would expect that there's a lot of the remote parts of Canada that are not seeing anything yet. But my brother lives in the middle of nowhere, South Dakota, and his community now has community spread coronavirus, and there's 2 documented cases, and they're expecting more. So it's going to be everywhere soon enough. That's the reality.
Yeah. No, it spreads fast, and I think 70% of us are supposed to get it. And the problem with the coronavirus is you're asymptomatic and you're a carrier.
Yeah.
I think the saving grace of SARS is you showed your symptoms quick. The problem with this is you don't show your symptoms fast enough.
Yeah. It's rough.
Yeah. I know. No, I absolutely. And so if you had to pick 5 things that you would recommend to the dental community out there.
Let's see. So
Carl Woodmansey, ticket to health.
Protect yourself. That's it. How do you protect yourself? You know, N95 or higher level respirator, eye protection, gloves, and a gown, limiting the number of staff for each procedure. working in closed rooms whenever possible instead of open bay operatories, and then cleaning and disinfecting your all contacted procedures and all areas where aerosols may settle, to try to clean your rooms as much as possible. Having some high volume evacuation, and then I don't know if you saw, I sent you a video showing a dentist that had a huge evacuator sitting like right over the patient's face. That may be where we're going in dentistry, thinking about what the future holds here. It certainly doesn't make sense for us to work in hospital level rooms to go get a prophy with an ultrasonic scaler that's going to produce an aerosol. That it's not going to be cost effective to have the same level of care that you go to get a colonoscopy or something like that. So we're not going to be going to it doesn't make sense to go to surgery centers or hospital level ORs, but we're going to need to find something that's a little safer than what we have, I think, going forward. And what that is remains to be seen.
What would you recommend as the pre-operative antimicrobial rinse?
Here in the States, we recommend Paradex, which is chlorhexidine 0.02%, I believe.
Yeah.
Yeah.
Okay.
It's like, I can't say that I know anything about its antiviral capabilities, but maybe they should use Canadian Club whiskey, Joel. I don't know.
Those stocks are sacred. We don't want those flying off the shelf.
Tequila.
Yeah. No, absolutely. But okay. No, that's some
and
great.
then also, I think just screening patients, what do we do? Yeah, it's got to be severe dental pain from pulpal inflammation. Can be pericornitis or third molar pain. Could be a dry socket, would be an example of an emergency that needs to be seen and managed, certainly. And then abscess, swelling, things like that. Tooth fracture with pain or soft tissue trauma. Traumatic injuries, the hockey pucks are still going to fly into someone's teeth, and we're going to have to manage those traumatic injuries as well. And then there's always, temporary crowns are going to fall off and need to be managed at some point. That may be a place where teledentistry can talk people into how to re-cement those themselves, or things like that too. So, it's a crazy world out there, and I hope our conversation at least makes your listeners feel a little comforted that they're not alone in this battle, that we're all going through this together.
Yeah, no, I think so. I think you brought up some great information, some great points, and this is a pretty good perspective on things. BC and Texas, and what happens is some of the guys are going to want to ask questions on the thing. This will hopefully get up in a couple of days, and the conversation is fluid. Probably a week from now, we'll look like idiots that it's wrong.
What do you mean a week from now? An hour from now? Yeah.
Yeah. Well, someone called me an idiot a minute ago. I was like, no, not yet. Give me a minute. But no, it's we gotta band together. Oh, one last thing before we go. How about pooling the resources as dentists? Like maybe picking Denton County or whatever, you're going to have two offices go to, one for the oral surgeon and maybe the endo guy, and one for the general dentist and the endo guy or whatever, and just.
I think that's a great idea, especially, and it's going to depend on each community's different. Like in Montana, we had really tight collective dental societies where people were really, they didn't see each other as competitors. They saw each other as colleagues. Yeah. And if we can all be colleagues in this, we can limit and take turns at having our turn playing roulette with the exposure. Certainly here in Dallas, our market here, and I don't know what it's like in Vancouver where you are, but we have a lot of, we call them dental service organizations, DSOs, or corporate group practices here. And those places have gone down to limiting which practices are open so that they're able to really localize the exposure to certain practices, and then rotating practitioners through there. There are even a number of large group dental practices. Dr. Patel here, Yogi Patel, who has, I think, 9 endo practices in Dallas, and they rotate. Only one of his offices is open per day, and the endodontist rotates, taking turns and taking care of those patients. But I think it is important to maintain some emergency care. Patients are going to need care. We can't abandon them.
Yeah. Yeah. No, all excellent points. I think we've run out of time. It was wonderful catching up with you, Carl.
Joel,
And
thanks.
I'm just going to hit pause here. I'm sure we're going to get a lot of responses to this.
Great.